this morning to present all of this. As you may or may not know, she is a clinical nurse consultant. She's been involved in the developmental disabilities field for some near 47 years. She is the president-elect of the Developmental Disability Nurses Association, and you know, you just can't touch her when it comes to the knowledge that she has in this field. And so you're going to spend an hour with us and learn many, many things. So we thank you very much. I want to call your attention. As a typical webinar, you are in listen-only mode. If you have any questions, you have the ability to submit them. If you look to the right of your screen, there's some information there that will allow that. You can certainly feel free to email things that any questions, concerns, issues, I would say itches that need to be scratched around any of the things that you might hear within the webinar directly to the email address that you responded to the webinar at, or you can certainly send it to me here at NYSRA, P-A-T, at the nyrehab.org, P-A-T at nyrehab.org. So I'm not going to belabor this introduction. We will ask you, though, at the end of the webinar to consider completing a very quick 3-question survey instrument that will pop up. This helps us identify further training ideas and situations that you might want and need assistance. We thank the Health Risk Screening Tool folks for helping us organize this. And at this point, I will ask Karen to say hello, and she may start her webinar. Karen?
Good morning. It's great to have so many folks. By my count, we were up to 146 at the moment. I hope that you all appreciate that talking about the Fatal 5 in 45 minutes, really we only are going to be able to touch the surface of these issues. And in fact, for 4 of the 5, we literally could be talking 1 or more days about each one of them. So I am going to try and give you a really good explanation of how we believe folks get in trouble and some of the basic things that you need to consider when you are trying to prevent what we call preventable death. In our field, I came into the field in 1965, and what Pat really meant when she said 47 years is, guess how old I am. And anyway, next slide, please. There's going to be a bit of a delay from the Fatal 5, and the 5th one really could, include a couple of other areas, but I chose what I believe for some folks are a couple of antecedents that lead them directly into trouble. Aspiration and bowel obstruction are really what I refer to as the big 2. And I'm going to talk about how come they come so close together and how and why it's so difficult to recognize what's going on with individuals whose communication styles are a little bit challenging. And so very often what they're going to do is to indicate to you in terms of behaviors what's going on with them because they don't have the words to talk about it. Next slide. I want to talk to you a bit about something that I think is really the issue with regard to the GI tract. If you'll notice that aspiration, bowel obstruction, and GERD affects this particular system of the body. And I think part of the issue is the design is a little bit flawed. I don't know how I do it better, but nothing gets into the stomach without having to first cross the airway, and that's the beginning of the difficulty. Whether it's going down or coming back up, we're in a lot of trouble at the point when food or stuff coming back up from the stomach has to cross into that area. And so I'm going to talk a little bit about the design because it's difficult to understand how to fix it. And for those of you in this audience who are 50 or more years of age, I promise you, you will sooner if not later, have some direct experience with that. I have a close friend who's in her mid-80s whose son decided to put her TV up in the corner of her kitchen so that she could watch it from her little kitchen table, and within 2 or 3 meals, she called him and said, you have to take that damn thing down because I can't look up like that without choking on my food. So the thing we need to understand is that the head has to be in a certain position in order for folks to swallow safely. The other thing is that the stomach is filled with noxious chemicals from which the GI tract is not well protected, and that things going down tend to be what we call gravity dependent. And when I talk to you about gravity, I'm sure a lot of you already have some direct familiarity with this. It's everybody who's over 30 in this room may have noticed that all of their body parts are sliding toward their knees. So it's a pressure that pulls down or pushes down at 2.2 pounds of pressure per square inch exposed to the vertical plane. The other thing I want you to be really clear about is that 2/3 of the medications on the market can impact on the function of this GI tract by interfering with saliva, interfering with all sorts of stuff, and causing a reduction in the stripping action of the gut. Next slide. Now, I'm going to talk to you a bit now. That little picture that you're looking at right now shows a tongue, and the tongue is the only skeletal muscle in the body that's only tied down at one end. And then you're looking at the esophagus. The esophagus, top third of the esophagus is skeletal muscle. The mid part of the esophagus is a combination, and the lower part of the esophagus, except for the lower esophageal sphincter, which is that little trap that should keep stuff in your stomach but often doesn't if you're in either bad position or you're under the influence of medication that inhibit its function. So what I want you to hear is that the tongue, the lips, the cheeks, the upper part of the esophagus, and the lower esophageal sphincter are all skeletal muscle. So if you think about the fact that the GI tract is a series of canals, think of the Panama Canal Zone. So you have to fill one before you can empty into another section, and that's exactly how the airway. When you swallow, you initiate something that we refer to as the primary peristaltic wave. Now think about how many people are not swallowing at all, are fed directly into their stomachs. They're not initiating that primary peristaltic wave, which then works its way down and then keeps on working until it gets to the end of the GI tract, which is that little muscle at the end called the anus. So again, this entire chamber is dependent on gravity for its optimal function. Next slide. Aspiration is the primary cause of death in most congregate care settings. Now, I just spent a week reviewing 24 deaths for a southern state in which I happen to be on a federal review panel. Of these, the end cause of death was aspiration in almost all of those deaths, with the exception of a few, because this is an aging population we're dealing with, that were caused by cancer. It is the second most common cause of death in the community. And in fact, if we looked hard enough, we might find a combination of bowel obstruction is the leading cause of death in the community. Aspiration is influenced by many factors, and I need you to hear that when you accuse someone of not being able to swallow well, you may be accusing them of the wrong thing. In fact, we may be really looking at aspiration that's happening because food can't get out of the stomach and is coming back up now with acid in it. And the nurses in this audience are well aware that if we send you to surgery with something in your stomach, your likelihood of aspirating stomach contents is very high. And in the case of aspiration of stomach contents during surgery, the survival rate is only 5%. So we got to get to the root cause, and that's the biggest problem. When you look at a problem-solving model, identifying the root cause is the most important thing you do and where you should spend most of your time. Next slide. Now, there are a lot of folks getting in trouble with swallowing, and all of us will be there unless we die very early. 75% of the time, I need you to hear this, it's very important, because aspiration 75% of the time is not about swallowing. So what we want you to think about doing is to begin looking at what happens with food before it goes down. Sometimes that's the root issue. As it goes down, does that person get into trouble and begin to aspirate? And with a lot of folks that I assess, I'm here to tell you that we don't see massive aspiration. What we see is aspiration 3 or 4 drops at a time over 20 or 30 years, to the point where we finally end up with so much obstruction in the lungs that the person is like a very long-term smoker. They just simply kill themselves a little bit at a time. The other issue is, does it go down? Does it stay down? And what does it take to get it out of the stomach? And then does it come out the other end? So 80% of the time, folks, in my experience, and again, my experience is with very severely involved people, 80% of the time the issue is getting it out of the stomach so it doesn't come back up with acid in it and destroy the lower part of the esophagus while it's at it. And then does it come out the other end is often an issue of the quality of the food. So that I did a series of trainings for the state of Georgia a couple of years ago, because they literally had, within a 5-year period, about 150 deaths from bowel obstruction. When we began to look at what was going on with all of those people, the average person who participated in our training got 10 grams of fiber a day, and a person with the disability, if we took a look at the quality of their food, was only getting 6 to 7 grams of fiber a day. And most of the nurses in my audience know that 25 to 30 is better. And then fluid makes an awful lot of difference, because if you don't increase fluid when you increase fiber, you're going to have another set of problems at the other end. Next slide. So again, bowel obstruction, the #1 cause of death in the community, largely because when you put people out, you are not giving folks sufficient information. Let's talk about that little bowel for a second. It is a very snarky little organ. Both the small intestine and the large intestine are going to get even with you if you have a problem. Because when we have one bowel obstruction, what we have left after that is a whole bunch of scar tissue, which means it's not a matter for me if the bowel obstruction is going to happen again, is when is it going to happen again. So what we need to provide to the people that we're moving our folks to, now that wasn't a very good sentence, but we have to tell them about the conditions, or what we refer to as the risk indicators. How do we know that something's happening here? For some individuals, they stop eating. For some individuals, they start getting bigger in the belly. For some individuals, they start behaving badly. And so it's very individual for each person, but I want you to think about providing information about the antecedents to the bowel obstruction, so that the person's providing for that person in the community is going to get what they need to know so they can intervene early. The other big issue for me, and a lot of you, I am sure, is that our ability to treat the person well is very much influenced by the negative perceptions of individuals with developmental disabilities. So when you go into the emergency room, I can imagine that for a lot of you that your experience has not been that people were exactly excited to see you. And in fact, a lot of times our folks are sent home from the hospital without having the issue resolved, and they end up going back with a really pushy staff member who says, look, this person is still sick, fix them. So our issue with people with the most complex disability has to do with their inability to communicate pain or other symptoms that they're having. And I will frankly tell you, it is almost like the little tiger with the little, a piece of stick in his paw. That you're so used to the discomfort that you don't feel it until it's almost too late. what I want you to realize is that rather than taking a look at the diet, what we do is we tend to over-rely on bowel management medications. And I think that we can do a lot more. I was up in the state of Wisconsin about 3 years ago, and I saw this young man whose big deal was banging his head. And he was banging his head hundreds of times a day. And so I said, let's go to your cupboard and see what's going on here. And we looked at the cereal, most of which was that sugary stuff with 0 grams of fiber. And I said, here's what I want you to do. I said, I want you to never again buy cereal with less than 5 grams of fiber per serving. I gradually want you to work this person up to 25 to 30, about 5 grams a week increase, and for every 5 to 7 grams increase, I want you to increase fluid intake. And I don't care what form that fluid is in. I don't care if it's fluid that's Jell-O or whatever. As long as the end product is a fluid, I want you to increase 8 ounces per 5 to 7 grams of fiber. So 2 months later, I got an email addressed to the bowel nurse. And this individual said, I just wanted to let you know that my friends, this guy, by the way, was also very distended, and his abdomen was quite hard. His function has improved markedly, but what's most important is that his head banging has decreased from 1,800 a day on the average to less than 10. So I thought that was pretty good, but the only real difference was they were, getting him to use that little system instead of having pain, because it is potentially fatal. Now, the influence of anticholinergic drugs on the lower gut, all of you, whether you know it or not, are directly experienced with this. So whenever you have a nice little issue with a cold, you get yourself something that dries you out, and it also strips, takes away the stripping action of the gut. So you end up being constipated. My personal experience is the influence of air travel, because I do about 100,000 miles a year. And I will tell you that for me, a good couple 100,000-mile flight is really miserable for me. So what I want you to do is to think about how we tell the folks who are out in the community or wherever when to blow the whistle on an individual. For some persons, because they're so used to that level of discomfort, we have to teach direct care staff how to identify when that person is beginning to distend. And for some folks, we do something called an abdominal girth measure, baseline. And then whenever they start to have some issues, we have them measure it again. And whenever they go 2 inches beyond the baseline, it's time to go into the panic mode. And again, I want to remind you that if a person has a history of bowel obstruction, the risk of a repeat instance is very, very high. So please be aware of that, and please help people plan and do risk factors and risk indicators. The risk indicator for someone might be that they start head banging. The risk factor is that probably it means that there's something going on with the bowel. Next slide. Okay, now remember when I talked about the fact that when people get accused of something we call dysphagia. Now, if you're really highfalutin, we call it dysphagia. But GERD, or gastroesophageal reflux disease, is the base issue for many more people, particularly folks with behavioral issues. So likely they've been on powerful anticholinergics, which we know are all of those drugs that impact on the neurological system. And that, by the way, also includes anti-epileptic medications. So one of the things that it does, by the way, that you may not be aware of, is it dries out the mouth. Now, I did a little article one time called The Cool on Drool, or The Skinny on Spit, because most people know that saliva is basic and that stomach acid is acidic. So because you make about a quart or more a day of fluid, spit, you're swallowing it, and its function is to lower the acidity of the normal, what we call refluxate, that stuff that comes up normally in all of us during that time, and it makes it more toxic. So individuals who are having lots of issues and who are taking many medications to control their behaviors or control their seizures are both diminished in the amount of spit, or particularly if you have a person who drools a lot, they're losing it, and it's not going down to do its job. So when stuff comes back up, and it comes back up for all of us, by the way, it just comes back up higher for other folks. So we may begin to be at risk for a massive GI bleed. We may have an issue with erosion of the lower part of the esophagus, and you'll start to see that, by the way, with people who are refusing to eat. And the most, for nurses in this audience, I need you to hear that for the most part, when you start to see blood, like the red count and all of those little factors that tell us the state of the system start to creep down, you may well be looking at a chronic esophagitis, and that's the impact of those stomach contents on the lower esophagus. And what happens is it's insidious, it happens very slowly, and I really assess some people in the state of Illinois who are getting it, because I watched them eat it, 12 to 14,000 calories a day and still not gaining weight. Now, sooner or later, those stomach contents are going to come all the way back up. And my favorite analogy for that is, let's pretend that you went to get a quarter pounder with cheese and an extra large French fries and a Diet Coke, and you gobbled it down because you only had 20 minutes for lunch, and then you worked the evening shift, so you got home and you laid down, and it takes fat, by the way, an extra amount of time to get out of the stomach. So pretty soon up it comes. And if you're lying down or not in a good position or you're sitting poorly is another really, really important thing to know about this. A lot of folks who are non-ambulatory sit on their low back as opposed to sitting on the bottom bumps on their pelvis. And so essentially they are pressing into the stomach and pushing stuff up. So again, do you hear this is more complex than it looks? Okay, issues that are life-defining are the side effects of the treatments, and I'm talking now about a group of drugs that a lot of your folks are receiving, which are called proton pump inhibitors. That is the stuff that is now available across the counter that most physicians that I work with are cranky about the fact that you can buy it now over the counter, because when you take that, it masks symptoms, and you could have a cancer of the esophagus going. But the other thing that we see is that it impacts on the amount of hydrochloric acid in the stomach, and that's where you absorb protein and where you absorb the stuff that, that causes your blood levels to be what they should. And so we see lots of issues, and I promise you in the next 10 years, some of the other things that are caused by lack of control of these kind of drugs are going to come out. So the other issue for me with regard to GERD is the failure to recognize and appropriately treat symptoms. Most of the individuals that I know, and a high percentage of them, have a lot of behavioral issues. And what they're doing, rather than saying, gee whiz, my gut hurts, they are beating their heads, they are sticking their hands into their mouths. And there was a book that is one of the best I know, and if I can remember it by the end, I'll tell it to you. 30% of the time when you have people who do this hands and mouth behavior, or individuals who are into pica, the issue has nothing to do with their behaviors and everything to do with the pain they're feeling down right at the point of the end of the sternum. And so what you're seeing is GERD, the effects of GERD, and how you're treating it is with drugs to control what you see is the behavior associated with that. So be careful, folks, and do try to rule out medical antecedents to behavior before you do anything else. Next slide. seizures. One of the biggest issues for me with regard to seizures, and we have in the most involved people a high percentage of folks with seizures. When I first came into the field, there were only two kinds of seizures, and they were called big or little. By the early to mid-70s, they'd come to the point where they called them hard, medium, or light. And the two categories are partial, so that only part of the brain is involved, or the other part has to do with a seizure that involves the whole brain at the outside, and that's referred to as a generalized seizure. But when you look at all of these things, what I want you to hear is that people, there are about 40 different types of seizures, and that doesn't even begin to count the seizure syndrome. So we only have recognized in the last 10 or so years that, that an aura, and most of you have heard that term, is really a partial seizure. So that the way we treat partial seizures is different than the way we treat generalized seizures at the outset. So what we want to know is this person generalized from the outset, or are they, having a partial onset to their seizures? And I always tell folks, look, there are two ways to know if it's a partial onset. Number one is, do you see after the generalized seizure is over some indication that part of the body is still involved? Like, are they drooping at one side of the mouth? Are they having some issues with still limping a little bit? And that's a pretty hard indicator that that was really a partial onset seizure. The other one has to do with watching a generalized tonic-clonic, and what we used to call a grand mal. Is the generalized tonic-clonic seizure the person moving equally on both sides of the body, or is one side of the body more involved than the other? And that's a dead indication that the person, in fact, has had a partial onset seizure. So that needs to be reported, and you need to ask some questions. And most of the tools that you use do not get at this issue, which is why I frankly prefer just a written descriptor of what happened with that individual so that the physician can get the tool, because a different set, most of the newer drugs now have to do with treating partial onset seizure, and if you treat the onset, you ain't going to get the rest of it, so be very careful. Status is a big deal, particularly if it's tonic-clonic status. That means you're having more than one seizure, and it's occurring one after the other, and the person is not having time enough to recover. It leads to respiratory suppression because you get a little swelling at the base of the brain, and pretty soon it starts to encroach on that bone that surrounds the midbrain. SUDEP, S-U-D-E-P, means sudden unexplained death in epilepsy. It occurs fairly frequently, higher than it should, in individuals, usually male, in their 30s, and they're doing fine, their seizures are probably well controlled, and then all of a sudden they're dead. So I invite you to look it up. I invite you to pay close attention to the risk factors for this, and I invite you to make sure that people understand that seizures of more than 5 minutes need to be treated in an emergency room where they can bring them under control as fast as they can, and for sure they can support the person's respiratory and heart function. Now, the big deal for me about a lot of the stuff we're talking about has to do with drug toxicity. As you know, I'm sure you do, and if you don't, listen to me very carefully. The drugs we most commonly give people with developmental disabilities are 8 of 10 of the top most dangerous drugs. And at the top of this list are anti-epileptic drugs and drugs to control behavior. And so one of the things that happens, for me, it's an issue of if you are taking 3 or more drugs, it's not an issue of if you have interaction effects, it's what kind are you having. So when I talk to audiences, I assure you one of the first things I tell them is the healthiest people with complex disabilities are on the fewest drugs. And what teams should be doing is saying to each other at the end, and try to do it nicely because physicians tend to get a little bit, threatened by this. Ask in the nicest way possible, and I will assure you that the definition of diplomacy is how to tell a person to go to hell in such a nice way that they look forward to the trip. So never do this in a why format. What you want to say, can you help me understand? If we look at these 12 or 15 drugs this person is on, are there some drugs that we really think are not doing much but interacting with the other drugs? And work toward reducing the drug load on a lot of your folks, because I cannot begin to tell you how much it impacts what's happening with them. So drug toxicity is real important, particularly on anti-epileptic drugs for some of the older classes of medication. Dilantin and phenobarb, by the way, if you're using those a lot, I need you to hear that we're not doing Dilantin and phenobarb. Most good neurologists, and the folks I like the best around this issue are what we call epileptologists, are now trying to get rid of phenobarbital and Dilantin unless they absolutely have to have it. Phenobarbital is, is a depressant, and it also interferes with a person's ability to think, and it requires good hydration in order not to get toxic. Dilantin, for me, is a drug that has been directly indicated or implicated in the number of deaths. It has a very narrow therapeutic window, 10 to 20, and minor changes in drugs, like if I were to increase Dilantin from 100 milligrams twice a day to 100 milligrams 3 times a day, I might see that person's drug level go from 15 up to 40. Which is in the toxic range. So I always want you to be very, very careful observing individuals when they're on this drug and when you're messing around with the levels. I don't have time to go in, and again, this is something we could talk about just about drugs for days. Seizure sequelae are. That is, when I'm saying this, I'm talking about what happens when a person has a seizure, or either during or immediately after. So at least 2 or 3 of the deaths that I just reviewed in the last week happen to involve, as the terminal event, aspiration. But they were the result of a person who had a seizure, then refluxed, and then aspirated within a few minutes after that seizure occurred. We also see any number of accidents with individuals, and in fact, my information is the death rate for individuals with seizure disorder, that is, their life expectancy is a fair amount less than people without seizures. Next slide. And when you look at the cause of death for most folks on their little, form, more often than you think, cardiorespiratory arrest is listed as the cause of death. Well, in fact, I've never met a dead person who was breathing or had a heart rate, so dying involves the, the cessation of breathing and heart rate. But death is always caused by something else that leads to this outcome. So I never accept that. It really makes me laugh if it is so not funny. Next slide. Dehydration. Now, I replaced dehydration for sepsis, which is also one of the big number. But I felt that this was a little easier for folks to get when you look at practices in residential settings in the community. What I think you need to pay close attention to is, why do people withhold fluids for people with disabilities? And if the person is incontinent, I promise you they're not going to get a lot of water after supper, because a lot of water leads to a lot of pee. And the quality of the attends or those kind of things is so bad that it pools and it dribbles all out. It's a lot of work for direct care staff. So I promise you, you have to help people understand that not getting sufficient water is a cause for side effects of many of our drugs. Phenobarb is probably the very best example. Remember, I worked at an institution in Iowa back in the mid-'60s when I first came into the field, and back in those days we didn't have air conditioning. And I don't know if you've ever enjoyed an Iowa July, but I promise you 105 is not an uncommon temperature. So if you're on phenobarbital and you don't get the water that you need, that toxicity increases. That is, the blood level is going to go right up. So when you don't drink sufficient fluids, you're also going to have increasing issues with bowel obstruction and or constipation. So there was a facility in Illinois about 10 years ago that simply increased and provided an extra 8 ounces of water at 10 o'clock in the morning and again at 3 o'clock in the afternoon. And they decreased their suppository load by almost 50%. So simple measures can provide a lot of, intervention efficiency for individuals, and it would probably do a lot for us as well. Next slide. So remember we talked earlier about the most important part of fixing a problem is figuring out what the problem is. And so the interdisciplinary process is designed to do just that. And if it doesn't include direct care staff, it probably isn't going to be very effective. What we need to do is to sit down and talk to staff and ask them and help them help us understand what really is going on. Next slide. Remember I said earlier the healthiest people are those taking the fewest drugs? If you stop looking for a magic bullet and start asking yourself, what can we do to help this issue? So I remember when Miralax came on the market, the miracle drug for helping people with constipation is never going to be as powerful as increasing fiber and fluids for an individual. And in fact, now do keep in mind that there are about 10% of individuals who have obstipation, and obstipation means, constipation that's on the verge of obstruction all of the time. They might have a different issue. That is, they might just have part of the gut that's not working at all, and so simply talking about fiber and fluids is not going to fix that. But you need to figure out what it is. Now, for the most part, it takes being an Iowa row hopper, I promise you that when the summertime comes and I can have all of the sweet corn I want, I usually ask folks, how long after you've had an ear of sweet corn does it take for you to see it again? And that's usually, for most people, about 24 hours. One of the things we know about individuals who are chronically on the verge of obstruction is that it may take as long as 5 to 7 days to get all that stuff cleaned out of their system. That's an important thing to know, because a physician friend of mine I asked him, I said, what's the solution to people who are backed up to their tonsils with feces? He said, you've got to clean them out and start over. So one of the things that he does is he goes after that residual stool and cleans it out and then starts over trying to get that bowel to function normally. One of the things I want you to hear is you've got to recognize the signs when your person is getting into trouble, and I believe they're always there. When I look back retroactively on a death review, I usually can pick up where it really started, and it maybe as much as 5 to 7 days ago. Where we professionals make the biggest mistakes is when we fail to recognize how much information the folks who spend the most time with the person have, and to talk to them about it, and to make sure they understand when they should start reporting that. So that bowel obstructions make me crazy, because usually we can find when the direct care staff started to tell you that there's something going on. And or with gland toxicity, for instance, they're going to tell you, oh my God, my person, I can't wake them up long enough to eat. And oh, my person hasn't had a stool for 5 days. And one of the things we are now doing in our training for folks with bowel issue is to train them to recognize what healthy poop looks like. And I'm sorry to be so graphic, but we do, there's 9 different kinds that we have them make with chocolate. So you take chocolate chips, chocolate pudding, chocolate milk, and God knows what, and then you give them a list of the 9 different kinds, of only which 2 or 3 are healthy. And because what they're reporting to you may be, they're reporting a small stuff, and what they're really looking is a smear of stuff that's coming around an impaction, or recognizing that when chocolate milk has chocolate chips floating in it, you probably have an obstruction, or at least, some obstipation going on. When in doubt, send the person out. I cannot tell you how many times I have reviewed deaths that had the person been sent out 24 to 48 hours earlier, they would not have died. Do not be afraid to advocate on your person's behalf. And if you have an individual for whom the managing physician is being a little uncooperative, do it anyway. People don't have to like you, folks, but you can save lives with these individuals by doing these kind of things. Next slide. Again, I want to repeat, never discount anything reported by parents or frontline staff. Trust your little professor. It's going to give you a tingle, and you're going to say to yourself, well, should I or shouldn't I? It always should be, I should. Always find a way to present your person in the best possible light. I can't tell you how powerful this can be. So you go to the emergency room and say, now don't judge this person by their appearance. There's a real bright individual in here with a great personality and a hell of a sense of humor. Help others see that good health is worth achieving, so that the more you move, the better off you are, and the more you move, the longer you live. So be an ambassador for your individual. Help people see the humanity. People are less willing to say we need a DNR order, we need to pull the plug, if you can help them to see that there's a real person there. Next slide. Here's something that I want you to hear. Now, you can get, by the way, a copy of this PowerPoint presentation. I don't promise it's perfect, but I promise it might be helpful to you in some ways. Always know if a person's condition is getting better or worse. Always know that. Don't let chronic health issues become routine or invisible. And whenever you hear this expression, there's, well, but he's always been that way. This person has always been headbanging 1,800 times a day. That doesn't make it normal, and it doesn't mean that there isn't something going on, because I wouldn't choose a headbang 1,800 times a day if I had something else to do or if I wasn't feeling bad. Your records must provide useful data about trends for the individual. So if I have a list of health risk factors and health risk indicators, I want to see data in your record that tells me how the person is doing on those issues. Make sure, now for me, ensuring continuity of care across providers is more an issue of healthcare providers. I think we've forced ourselves to take a look at, people in the day program need to know what the people in the residential program. What I'm worried about for most individuals is they have 5 to 7 different physicians or, primary care providers, and they don't know anything about what the other is doing. And I've always maintained that the best model for that is healthcare coordination that becomes a primary responsibility of nurses in your system. And if you're not using your nurses this way, you're making a really big mistake. And I want you to consider allowing monitoring of residentials on these kind of factors so that you can assure health and safety. If you have a few individuals discharged from the hospital where one of the primary diagnoses is dehydration, you go look at that person's residential and day program setting and see what kind of fluids they're getting. There's something going on in terms of how the person's are being managed. We have a number of those kind of factors that we need to consider. And I see that I am now out of time. Do I have another slide, Rob? I do. This is my contact information, and I promise you I'm always willing to talk to folks. and my email address. But what I'd like the nurses in this group to consider is joining our Developmental Disability Nurses Organization, because there's going to be a major presentation on the Fatal Five, not by me, by someone else. And our annual conference is worth membership alone. And we are having our annual conference the third week in April in Philadelphia. And the program is just stunning. So please contact us. And if there's any clarification or other things I can do to help you, don't hesitate to contact me at my email address. So I think I am finished.
Okay, Karen. Okay. Hey, I'm going to help you out here. There's a couple of questions that have come up. So the first one, and I'll read it to you here, and then I'll let you answer. One question is, how do you feel about the use of probiotics for colon health?
I take them myself. What does that tell you? I think they're really beneficial, because what we've done for the most part is to knock all the healthy bacteria. You know, 70% of your immune system sits in your gut. And I have a really interesting article about the brain in the gut, which is, I'm happy to provide some information about how to look at this article. It's in a book called The New Scientist from last month's journal, and it's just a fascinating read. But I'm into natural, you know, remedies more than any other thing, and then we resort to medications last. So, any other? Do you have another question, Rob?
So a question here is, how can we get a copy of the PowerPoint presentation? Pat, please let me know. I was going to suggest that they email NYSRA and they can get a copy of that. As well, this has been recorded, and we should be able to supply a link to a recording of this by Monday.
Terrific. Yes, if you send an email to that to my email address, pat@nyrehab as in boy.org, nyrehab, we'll be happy to get any information out to you, including, I was going to say, Karen, if you want to share the dates and the link to the DDNA conference in Philadelphia, we'll be happy to post that as well. We certainly continue to provide resources to nurses in New York State on a regular basis, so we'd be happy to distribute that information and share it as well. Thank you very much. Any more questions, Rob?
Pat, could you give your email one more time?
Sure. It's pat@nyrehab as in boy.org. And I want to remind everyone, before you walk away from your screens, there will be a short 3-question survey that will pop up. We value your extra couple minutes to fill that out for us so that we can look at what to present and develop for our third and final part of our series with Hurst and certainly with Karen Green McGowan, the extraordinary trainer that she is. So thank you, Karen, very much for taking time this morning to share all this wonderful information that you have to everyone. We will be looking to put on one more webinar in this mini-series of information, but certainly if you're valuing this and would like more, do not hesitate to send an email to Karen or to me, or on the survey instrument, please indicate that this is a value that you'd like to see continue, and we will work together with Karen and Rob at Hurst in order to bring this all together for you guys. So thank you very much for joining us this morning. Thank you, Rob. Your technical expertise is getting better and better. And, of course, Karen, you're phenomenal. Thank you all. Have a wonderful day.